Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thank you so much for listening to Behind the Knife. This is Patrick Georgioff. I want you to imagine this. It's 2 a.m. and you're rushing a hypotensive trauma patient to the operating room for exploration. Maybe you need to go into the neck, the chest, or the abdomen. Are you prepared for what you might find? Trauma educational resources are extremely limited, and that's why we created the Trauma Surgery Video Atlas. 24 challenging scenarios with high-yield text, beautiful illustrations, and stunning professional-grade video that walks you through the approach and management of devastating injuries in a step-by-step fashion. Check out the link in the show notes for more. There are group discounts available as well. Now, enjoy the episode and dominate the day. Thanks for tuning in. This is Patrick Georgioff with Behind the Knife. Every spring for over 50 years now, the Trauma, Critical Care, and Acute Care Surgery Conference, best known simply as the Mattox Conference, is held in Las Vegas. The conference is unique in that it is entirely focused on practice-changing clinical education, a lot like what we focus on at Behind the Knife. It's also a really good time. Now, one of the favorite features from the conference are the annual debates. Today, we are featuring a showdown between Drs. Teddy Puzio and Joe DeBow as they battle it out over the use of a direct-to-OR trauma resuscitation strategy. You can listen on the podcast or watch the debate with the accompanying slides on our website or app. Dominate the day.
All right. We will bring our next two debaters to the stage. Similar ground rules today, gentlemen. 12-minute opening with a 1-minute follow-up. Resolved. The stability challenge. Unstable patients should go directly to the OR. Two fine contestants today. Taking the pro position, Dad Puzio from University of Texas Houston Health Science Center is going to take the pro position and kick us off. Welcome.
Whew. All right, another rookie. Thank you, Dr. Mattox and Mary. This is another David and Goliath. So my disclosure is I'm a lover, not a fighter. So have mercy on my soul. I think I'm going to actually support both of the previous speakers as we go through this. I realized that as I was sitting there. So, all right, got a question for everyone. Is there anyone in this room that thinks either of these patients should go to the emergency department to get something done in the ED that you can't just do in the OR? And I think that's an easy question, right? Everyone can say, the paramedics know this, the firefighters know this. We could probably go downstairs to the casino and ask people, and they say, oh, these patients need an operation, right? They need a surgeon. These are easy ones. Well, what about this patient? And I think this is the patient that, this system really is about. So the 23-year-old gunshot wound to the abdomen in the back, heart rate of 140, systolic of 70. This patient has hemorrhagic shock from truncal penetrating mechanism. They should not stop in the emergency department. They should go directly to the operating room. And we're going to talk about why. The first question is, well, when do bleeding patients die? And this has been talked about. We've heard about it today. This is an older study from our center, but this, people will say that's kind of a long estimate, but the median time to death in this study of 1,000 trauma deaths was 99 minutes. So that's kind of our target, right? How does this work when we think about the patient? So time zero, the accident occurs, or they're injured. The average EMS response in the US, somewhere around 7 minutes. So it takes 7 minutes to get there, and then to the trauma center, anywhere from 30 to 70 minutes. So we're looking at, let's say, 40 to 80 minutes before they hit the door, right? This is something that we can't control. But what we can control is what happens next, that time from the ER to the operating room. That's what we can affect. And again, let's say 99 minutes is our theoretical target. So there's some studies that look at, as Dumas said, it takes a lot. We spend a lot more time in the ED than we think we do. This is a study from the UK, looked at 1,600 patients. So you can see in the blunt trauma, they had 56 minutes in the emergency department, penetrating a little less, 37. Maybe you argue, well, that's in the UK, or maybe they didn't use video review, right? They should get better. That's a long time for those patients that needed a laparotomy. But this has been replicated. This was in the US. So they looked at 243 hypotensive patients that needed emergency laparotomy. And what they found was median time was 55 minutes, right? That's a lot of time for these patients that are dying and they need surgery. And they also found the probability of death increases by 1% for every 3 minutes in the ED. So like every minute that ticks by, your risk of death for these patients increases. I like this one, right? I think maybe this is a good study that could be redone with video review and see if they can find more results. So they looked at opportunities for improvement from their medical record, actually. So 423 deaths from hemorrhage, 150 opportunities for improvement, and over half of them occurred in the emergency department. So this is the normal flow, right? We said 40 to 80 minutes, 50-ish minutes in the ED to the operating room. You can see the average time there. That's a lot of time. Well, I think as Dr. Joseph said, maybe if we just get rid of video review in the ED altogether, just get rid of the time in the ED, and that debate is closed, right? We don't even have that debate anymore. Just go take this patient who we all know needs an operation and go straight to the operating room. And that's what we're talking about today. I think that's I'm the pro position. But this is not a new idea, right? This is actually a really old idea. Again, I'm a rookie, so I don't know if anyone's ever talked about this at the conference, but this was actually described in the 1960s, which is surprising to me. So at University of Louisville, they talked about 10 years of doing this, and it was for cardiac stabs. They actually operated, their OR was in the ED, which was pretty cool. But if you look at the literature, so PubMed, it kind of died out right after that, right? There's not really much literature on this concept until really the last 10 years is when people started publishing on it again. The first question is why? Like, why would you even want to do this, right? Well, I think time is the most important thing. And we've heard a lot about pre-hospital resuscitation with whole blood, but getting them to the OR for definitive hemorrhage control is important. There's a lot of studies in your syllabus that I outlined. Here are a few, and the theme is the same, right? You can see the first one. Scene to OR, 11 minutes. Surgical start, 13 minutes. Median time to surgical intervention, 23 minutes. That is a very short amount of time. So if it shortens our time, people argue, well, who do you do this on, right? We can't just take all our patients to the operating room. We can't, take patients that blunt trauma with a lot of other possible areas for bleeding. So I would say the indications vary, and you kind of have to figure out what works best for your hospital and your EMS agencies. And I'll give you some examples of that. So we look at 2 papers published on this. So Dr. Martin et al. You can see on the left, that's their criteria. Pretty liberal. There's a lot of things on that list that would get you going directly to the OR. And you compare that and contrast it to the criteria on the right, much more limited. And I can tell you that in our center, our criteria is much more limited because if we follow the one on the left with our volume, you would overwhelm the system, right? So you have to look at your system and your resources and figure out how to make this work. We've also published on this some of the criteria that we've used for this direct to operating room score. But, some of the critics would say, well, as you can see, we have pre-hospital fast, and that's not across all spectrum. So we're trying to revise this and see if we can kind of eliminate that and figure out how to better our criteria for these patients. So how does this system work, right? Who triggers this system? How do you initiate this? Well, I can tell you again, it varies by center. Sometimes it's the EMS agency, sometimes it's the surgeon, sometimes it's even the ED physician who takes the call. So for us, it depends on whether it's a helicopter crew or it's a ground agency. So if it's a helicopter crew, I get a phone call, and I actually have the helicopter crew saved in my phone. So and they have a special ringtone. So when they ring, I know that, this is going to be something good because the helicopter crew's calling me. And you pick it up, and they're like, this is the patient that we have, the mechanism, and they on scene say, hey, we should go directly to the OR. And then I say yes or no, and it sends a page out to the system, and everyone kind of convenes in the operating room, and we make this, the resuscitation starts in the operating room. But there's no I in team, right? We've all heard that. I love that phrase because it's not, we could all sit here and say, oh, this is great, we should do this. But just as trauma surgeons alone, you can't really make this happen. You have to have buy-in from the system, right? Your anesthesiologist, ours do ATLS, and they train with us on how to resuscitate patients. The blood bank, we've heard a lot about that. They are on board with this. They bring the MTP coolers to the operating room. Patient registration, we learned the hard way. This is also a really important point because everybody gets really flustered if they can't document on the patient, and this was a kind of a hiccup when we first started. OR nursing, they need to know X-ray, even the emergency department, because there's what I call the fake news patients, right? So we've had patients that go to the operating room, we initiate this response, and then all of a sudden you find out they may not need an operation. I had a patient that had a carotid blowout, and the medics came in holding pressure on their carotid blowout, and we get to the OR and we get ready to intubate them, and we take pressure off the carotid blowout, and it was just blood from a scalp plaque that had fallen onto their neck, and the medics were trained to just hold pressure. But, we have an algorithm for that, right? We just aborted this OR pathway, and we went to the ED, and we made it work, and it was fine. This is what the system looks like. You can see here, controlled chaos. But I think when I think about this, it's kind of like a NASCAR pit team, right? Like anybody can change a tire. But in order to do that really well, you can't just show up on a Sunday, on race day, and just do this as a team, right? It takes a team to do this. And I can tell you that this is kind of like a quality improvement project. We sat down with all the stakeholders and figured out how are we going to do this as a system. Once we created our protocol, we practiced, right? We had a mannequin and we ran through the scenarios, and then we decided kind of what was working, what wasn't working. And even when the system was in place and when it's working well, we still do feedback. We don't do video review, but maybe that's a thing for direct to OR. So this system is something that you can implement based on your center and your resources. And I included a QR code to our guidelines just to get an idea of how it works for us. Turn it over to Dr. DuBose. Thank you.
Thanks. In keeping with the taking the lambs to the slaughter, I have to say that was the most gentlemanly debate I don't think I've been here one time and not see the debater take a single. No, don't applaud that. I didn't see one shot taken at Joe DuBose, and trust me, there are plenty. Let me bring the composition debater to the stage, Dr. Joe DuBose, incredible history of service to the United States in his military service, and now professor of surgery down at UT Austin, taking the composition. Please welcome Joe DuBose to the stage.
Well, thank you. Yeah, he speaks softly, but he carries a big stick. So, and I'm going to self-deprecate a little bit to make Dr. Puzio's job a little easier. My conflicts here don't matter. I mean, look at this guy. He's a rising star of trauma care. And you dig into his history, it's always good to size up your opponent. He's a former rescue squad, fire department volunteer. He's well-trained, practiced, clearly well-composed. I mean, you look at health grades, he's got 5 stars. Patients write damn essays about how good this guy is. Incredibly safe and quite comfortable with his medical decision making. Of course, I'm a little bit daunted at this point, right? I mean, you put me up against the firefighter, Dr. Mattox. Thanks, Allison. Appreciate it. But he also has a lot of experience at their center. If you've ever been to UT Houston and seen their hybrid trauma OR, man, as a dual practicing vascular and trauma person, I had to wipe the drool off my coat when after they showed me this thing. And he's written quite a bit about it and shown us that this can work and is the way of the future in some ways. And, by comparison, I'm the proverbial punching bag of the Mattox faculty when it comes to debates. I have gotten that Mattox. You can see here the record and the injury reports. The dental work I needed after going up against Mattox in 2018 alone set me back for 2 years financially. But I was born in the state of Texas. I know the story of the Alamo, so let's close the gates and let's get to fighting and swinging our things. So why direct to the OR? It makes total sense. Rapid hemorrhage control, that's what we do. Stop patients that are bleeding. Definitive hemorrhage control. Let's get there as quick as we can, quit futzing around. But my bias here is that deliver you a hybrid operating room. And I will say, if you're going to do this, that's where you should go. Go where all the hemorrhage control interventions are capable and present. You bring that full toolkit, it might be a challenge here. So my humble considerations are that for all the resources and effort you need to make this happen, how often do we really need it? Pretty expensive modality to bring into bear. And are there select circumstances where kind of slowing from a sprint to a jog might actually prove beneficial to the patient, particularly as it applies to the use of some critical imaging? We don't live in the world of single-site scanners that take 30 minutes anymore. You can stop and get a head CT in about 30 seconds. So this is Dr. Puzio's own data, 2-year study, approximately 40 patients per year that they enrolled in this thing, right? Not a big 10% of the patients that met the criteria for inclusion here. There's a myriad of studies. I gave some of this in the innovations. I talked about the hybrid OR. This is the Raptor room, and again, a very capable hybrid capability in Calgary that they introduced in 2014. 35 patients over 6 years were effectively used for this, right? And they had no difference in outcomes. So what are the risks of going direct to the OR and bypassing kind of the acute imaging that we're taught may be important in the trauma world? Well, I really think it's specific injury patterns we have to think about that we might miss that might have actual detriment for the patient. And that includes traumatic brain injury, spinal cord, and some thoracoabdominal injuries. So does a delay in TBI diagnosis and management matter in these two patients? I would contend it does, and there's some data to support that. Right? So the decompressive craniectomy literature is fascinating and a whole separate debate, but several systematic reviews have shown that when you have a delay in decompressive craniectomy, i.e. taking someone to the OR for an X-lap that may not be needed or just to put in a chest tube or intubate somebody, we create a situation where we may have significant detriment for the patient. Here's another systematic review, and it's fine print down there in the bottom, but their contention here, and I agree with this, is that early decompression of the cranial vault in patients who need it saves lives with patients with TBI. And we can make the same debate for spinal cord injury as well. There's certainly neurologic injury in general does not lend itself to being ignored for very long. We know that delays with transfers for spinal cord injuries have significant detriments, significantly higher 30-day mortality, and a host of other adverse outcomes. And even intra-hospital, this is an ACS TQIP study conducted over 6 years that found amongst thoracoabdominal spinal cord injury patients, delays were associated with significant increases in major complications. Do we miss diagnosing these by taking the patient to the operating room in a direct to OR pattern? What about thoracoabdominal injuries? You get in the wrong cavity, right? Some of these can be a little tricky, and there's multiple papers that have been written about this. From my own former training background, Dr. Dimitriades and Dr. Asensio wrote about this. 4-year retrospective study, 254 thoracoabdominal injuries. 29% needed a thoracotomy and emergent laparotomy, but most importantly, inappropriate surgical sequencing occurred in 44%. They got in the wrong cavity, and if they just stopped to get a CT scan, they might have been able to move more efficiently and effectively through the patient's care. And then there are some other studies here that have talked a little bit more that I think are worth highlighting about direct to OR. Matt Martin, sitting over here, who's also whooped my ass in debates before, has done some nice work on this. And they've looked in 2021, they reported the first of their 2 series and found 104 cases, and direct to OR actually had a negative impact in 9% of those patients. Is that something we could ignore? Did they miss something with CT scan that they could have diagnosed expediently? Now, I know what you're saying. This is the part of the talk where either people think you're crazy or they're coming after you with the torches. If we had mics in the aisles, the old gray-haired fellas and ladies would be up telling me I'm nuts to say we need to get a CT in an unstable patient. Right? But the practical reality here is that instability is a bell curve spectrum, right? Just because you showed up to the hospital with blood pressure of 75 doesn't mean that after 500 units of blood, of crystalloid or blood that you're now not stable enough for a CT scan, which can be done in a matter of seconds when it's really focused utilization, looking at the head and other areas that you're concerned about. So there are non-responders we just have to run to the OR with. It's just a practical reality. But the responders and partial responders, maybe we have time to get a little bit more information that can guide us. And is this dangerous to get imaging in the setting of hemodynamic instability? Sure, there are risks, but those risks have to be outweighed. And I think that this is a Cali study from Cali, Columbia. They took 171 hemodynamically unstable patients, about half of which went to the OR, half of which went to CT scan. And with the CT scan, surgery was avoided entirely in 54% of patients. And it was helpful in deciding definitive specific surgical management in 46. Importantly, there's no difference between direct to OR and CT patients in this particular study. So that small, very brief pause with modern CT scanners didn't have any detrimental effects. So I'll say my initial points on this is the direct to OR, I think, has probably limited applicability relative to the resources that we're throwing at it in terms of the capabilities. There are important subsets of patients that if we move too fast, we're going to miss some things. And the number of patients likely to benefit from appropriate rapid imaging is probably larger than the number that will go to the OR. Now, I'm going to go off script here because I got more time, and I'm going to do my rebuttal here as well, right? Again, I'll come back to this guy. Look at him. I mean, he's a rising star. By comparing, I mean, he's even got the smirk down for the Brad Pitt. They have the same smile. And I stand before you looking like Professor Dumbledore from the Gryffindor School of Hobory, okay? So I understand appearances, and I know I'm up against it again, and my record's likely to go to 0-9, and I'm okay with that. And I am largely convinced by the work that Dr. Puzio and them have done. But my real kind of secondary point here is if direct to the OR is good for some patients, how do we optimally identify them? Because I see a lot of struggles in that battle space. We'll go to Dr. Puzio's own paper. Here's something I love to do with papers, a little kind of master's class that somebody taught me along the way. If you Google, you can now search, right, within the context of these things. If you put interestingly, that is where, after that word interestingly, this is where everybody puts the data they don't know what the hell to do with. So I did the same thing in this paper. One interestingly showed up. And it is, as Dr. Puzio well knows and appreciates, that's why he scratched his head, of their comparator group, the patients who did not go to the OR, the majority of them had scores that indicated they should have gone. Yet those patients did pretty well with some of them needed a surgery in an hour, probably could have gotten some CT imaging in that hour. And if I do the math here correctly, about 12 of them didn't need any operation in the first 20 hours. So, the interestingly thing played off here because I think that highlights our inability to accurately define who these patients go into the OR with. I'll come back to Dr. Martin's work, who's done 2 papers on this. The 2021, only 41% underwent an emergent laparotomy or emergent surgery after going to the operating room using their criteria. And direct to OR in retrospect was deemed to improve care in only 63%. That's being wrong a lot of the time. Dr. Martin followed on with that to show us that really the only independent predictors associated with the need to go to the direct OR was ISS. Well, that doesn't get calculated by my trauma registrar 2 months from now. That's not helpful to me at all. So how do I even identify these patients real time? They followed on, this is fresh off the presses, February of 2025, looking at I assume the same 104 direct OR patients. They just went back and did another project using the same data, which is a tried and true method of academia. But largely they went, and the majority of patients selected for direct OR deemed appropriately triaged, but only 44% had perceived benefit from the direct OR. So even when you set up the best criteria you can, using all the science you got, you're going to be wrong over half the time. So even if DTOR policies are useful for some patients, I think they're very infrequently required. There's a disproportionate amount of resources relative to impact for patient care that we're giving, and you probably actually hurt some patients by bypassing imaging that can change their care for the better. Thank you.
Dr. Puzio will give you 1 minute for a rebuttal. And by the way, just a debating pearl for next time you're up here. When a man's walked around with an Uncle Jesse beard, he even put his own selfie up there. You should have had a cell phone shot of him earlier this week. All right, we're educators here, folks. That's what we do.
Well,
Dr. Puzio.
I would say last week my wife told me I looked like a trauma patient and I needed a fresh haircut for the conference. So I appreciate your
Very nice. It's
very positive feedback. I would say this system of direct to OR, we don't use for blunt trauma patients. I think they're way too complex. There's too many factors. So I would say penetrating only and penetrating hemorrhagic shock patients only. It seems to be the patient group to go after.
All right. Outstanding. Well, if we could bring the house lights up, I'm going to ask a couple of questions before we go. Dr. Puzio, who trains the paramedics in your system?
It depends on the crews, but we have a anesthesia provider who has a medical OMD, and then there's ED docs, and then we, the surgeons as well, train them.
And what about Houston Fire?
Emergency medicine.
Okay. Joe, how does that work in Austin?
Much the same. You know, Central Texas is really a disparate group of. It's hard to get people together around the campfire. It's very different than other locations I've been at. And I know Houston has a little more central control because they own the air assets.
Yeah.
And so the highest end of those trauma injuries that come from furthest and need the most attention, they have a little more control and influence over. We don't necessarily have that same degree within Austin, where most of our patients come by ground.
Our main helicopter crew, the medical director, is one of our partners. So trauma guides that, and we do most of the training for the medics. That's why that was the criticism to our scoring system was pre-hospital fast. But we train them, and we have like pretty good competency requirements for them. So we feel comfortable when they call us and say, "Hey, doc, the fast is positive," and we go off what they tell us in the field. So we have to trust them.
Well, I just will end this before we vote with a story. A few years, it's been a bit more than a few, but several years ago, Dr. Mattox and I got invited together to an emergency medicine conference. It was a room like this, thousands of ER doctors. And I gave my talk, was very professional. It was Dr. Mattox was going to give his talk, and we're going to go to the airport and go home. And he said to all these ER emergency physicians, he said, the only role of the emergency department in the care of the hypotensive penetrating trauma patient is to wave at the guy when he goes on by up to the operating room. And we evacuated very quickly, so we didn't end up trauma patients. And shockingly, at least he might have been, but I was not invited back. Guilt by association.
All right. After
Let's
rebuttal,
go. Let's vote. Let's vote. All of those who believe that Dr. Puzio carried this topic, please raise your hand. We might be seeing Mattox Conference history with Joe DuBose's first win. If you believe Dr. DuBose carried the day today, please raise your... Oh, my God. Heaven help us. Ladies and gentlemen, his first win, Joseph DuBose.
My first win.
All right. We will take...
No, we won't. I have an executive question on this debate. I have criticism of the program committee that we asked the wrong question. The military has put the emergency room tent, the operating room tent, and the ICU tent right there together. I have seen recently, Japan has made a gantry. You come into a location, patients put on that gantry. The CT scanner is right there at a punch of a button, and that same gantry is the operating room, and the ICU is right there next door. Maybe the question ought to be a redesign of our acute care surgery, trauma surgery location in the hospital, rather than making it on the first floor, the fourth floor, down the hall, across the parking lot, and maybe the whole concept in the way we built hospitals, even now, was incorrect. You can comment on that if you wish, but it suddenly occurred to me, maybe we asked the wrong question.
Yeah, I will just say, having seen some of that Japanese data and some of the videos that are out from there, for those not familiar, Japan, they don't have like a trauma surgeon in-house, right? So it's an interventional radiologist and the ER doc that partner to do this, and they have a head seat. You come off the gurney. I showed some of this in the Innovations Conference, or at least a couple of slides. They come off the gurney, they go on a bed, they get a full CT scan, and they proceed immediately to access an interventional hemorrhage control. And it is literally like the NASCAR paradigm with how fast it is. So I think Jun Matsumura was here he had a session earlier this week. If he's still around, ask him to show you some of that stuff, because I agree with Dr. Mattox. It is a very impressive innovation in trauma care.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.